Hey everyone, I hope everyone's having a great Saturday. Here is my literature review on non-STD vaginal discharge. We'll start things off on slide 2, and that's the objectives, and they are the following. Identify how risk factors are associated with vaginal discharge. Describe the pathophysiology behind this. State pertinent positive and negative H&P findings. Identify and distinguish common presentation of the different types of vaginal discharge. Identify red flags associated with vaginal discharge. State different diagnostic methods utilized to evaluate vaginal discharge. Understand and attain the ability to devise a treatment and/or management plan for vaginal discharge. And lastly, identify key areas of education, monitoring, and when follow-up is needed. Moving on over to slide 3, during reproductive years, vaginal secretions are normal, regularly occurring, and it is estimated that 10 million gynecologic healthcare visits each year are related to this chief complaint. The numerous variations in the amount and characteristics of vaginal secretions are determined by physiology, timing in the relation to menstrual cycle, use of local or systemic medications, sexual practice, and pathology. Vaginal discharge can cause a decrease in quality of life for women because it is often caused by an abnormal function, as with recurrent problems if it is not properly identified. The major reason for abnormal vaginal discharge is not caused by STI infections, but caused by non-infectious processes such as a physiologic process. Examples of a physiologic discharge can be due to age, hormones, or local factors such as menstruation, IUD, or postpartum. Another main cause of vaginal discharge is by a pathologic origin such as bacterial vaginosis, vaginal yeast, or trichomoniasis. Knowing that the majority of infectious causes of vaginal discharge are related to changes to the normal vaginal environment, it will be important to identify such cases. Next slide, we're going to go over the pathophysiology and anatomy. To identify an abnormality, we must first be aware of what is considered normal. The vulva and vagina are covered by stratified squamous epithelium. The vulva contains hair follicles and sebaceous sweat and apocrine glands, whereas the vagina epithelium is non-characterized and lacks these specialized elements. During puberty, maturation of the epithelial cells that occur with estrogen stimulation increase levels of glycogen in the vaginal tissues, which favors the growth of lactobacteria in the genital tract. Glycogen is broken down by these bacteria to lactic acid, which ultimately lowers the pH range from 6 to 8 to the normal range of vaginal pH range to 3.5 to 4.7. The vaginal pH of 6 to 8 is normal prior to puberty and after menopause, whereas the pH of 3.5 to 4.7 is normal in the reproductive age woman. There is also a wide range of other aerobic and anaerobic bacteria found within the vagina, which is a normal finding. The vagina is considered a potential space, not an open tube. Therefore, a ratio of 5 to 1 anaerobic to aerobic bacteria is normal. The source of vaginal secretions arise from several sources. Most of the liquid portion consists of mucus from the cervix. A small amount of moisture is contributed by endometrial fluid, exudate from accessory glands such as skin and barrel thin glands, and from vaginal transudate. The white to off-white coloration of vaginal discharge is the result of exfoliated squamous cells from the vaginal wall. This exfoliation also increases the consistency of the discharge. The action of this indigenous vaginal flora also can contribute to the secretion. The role of these secretion is to provide physiologic moisture, which prevents symptoms of dryness and irritation. The amount and character of normal wetness is under the influence of factors such as hormonal and fluid status, as well as pregnancy, immunosuppression, the practice of douching, and sexual activity. Moving on to our next slide here, We're going to discuss risk factors. The following are risk factors for the development of the three conditions which produce non-ST vaginal discharge, and that's the three most common. The first is bacterial vaginosis, which is the most commonly caused by disruption of healthy bacteria, leading to an overgrowth of anaerobic aneurysms. Risk factors include race, which is it is more common in African Americans, smokers, the individuals who practice vaginal douching, spermicide use, having multiple sexual partners, and having a low social economic status. According to Sherrod et al., African American women have a 45 to 55% risk of developing vaginal discharge, whereas Caucasian women have a risk of 5 to 15%. The main reason I found while researching this was vaginal microflora. Women of European descent are more likely to harbor lactobacilli dominant microbes, whereas African American women are more likely to exhibit a diverse microbial profile. Next is vulvovaginal yeast. Is caused by Candida species. Risk factors for Candida infections include immunosuppression, diabetes, recent antibiotic use, corticosteroid therapy, HIV, and conditions associated with high estrogen productions such as pregnancy, oral contraceptive use, and hormone replacement therapy. Next is atrophic vaginitis, and it is most often caused by a lack of estrogen secondary to menopause. This condition can happen in the postmenopausal period due to loss of estrogen from the placenta and provoking an effect of prolactin on estrogen, which occurs during lactation. The other risk factor identified by Bachman are related to a loss of estrogen and includes a decreased ovarian function, oophorectomy, immune disorder, medications which contain anti-estrogen properties such as tamoxifen, and cigarette smoking, as well as nulliparity in the cessation of coital activity. So on next slide, I'm going to discuss history and physical findings. 90% of vaginitis cases are caused by bacterial vaginosis or vulvovaginal yeast or trichomoniasis. Thus, evaluation of vaginal discharge should be focused on these three etiologies first and foremost. Look at the most common culprits first. The history of present illness should include the onset of signs and symptoms, duration, description of discharge and associated symptoms, aggravating and alleviating factors, time of discharge such as does it wax or wane, and severity, either pain/discomfort affecting quality of life. However, many women, aside from having abnormal discharge, are asymptomatic. The obstetric and gynecological history will resolve around menses or lack thereof, sexual partners/practices, contraception, gravity, and fertility. These may seem like a broad category to cover, but it is important to obtain this information in an attempt to identify the cause of the vaginal discharge. If the woman is of reproductive age, it is likely to be either a physiologic or pathologic basis behind the vaginal discharge. Either fluctuations in hormones or an infectious process could be going on. For a prepubertal or postmenopausal woman, hormone fluctuation is less likely and the cause of vaginal discharge, so one may shy away from a physiologic differential. We will want to obtain information revolving prior menstruation, and if the woman has noted any changes, we also need to ask the tough questions, and those revolve around sexual practices and preferences. So, does the patient partake in anal sex or utilize sexual toys? How many sexual partners do they have? The utilization of contraception is key to this discussion. Do they utilize contraception? If so, what do they use? Pills, condoms, IUD, withdrawing method? We must obtain this information to narrow the potential etiologies behind the chief concern of vaginal discharge. In regards to the obstetric history, has the woman been pregnant or given birth before? If so, how many times? Does she remember if her vaginal secretions changed during this period? Also, has she had a hysterectomy? If so, what percentage of her female organs were removed? This can help narrow down the list of potential differentials by decreasing the risk of malignancy if the patient had a total hysterectomy. Family history should revolve around the prevalence of cancers in first-degree relatives, as this could be a potential etiology behind vaginal discharge. What factors are predisposing this woman to develop abnormal discharge? Does she smoke? Does she drink? Use illicit drugs? What is her nutritional status? Is there any chance of sexual abuse? These questions must be obtained prior to moving to your review of systems or physical assessment. The review of systems either may be specific or extensive depending on the severity and nature of the vaginal discharge. Pertinent positive and negative findings regarding the ROS for vaginal discharge will focus on constitutional, throat, respiratory, gastrointestinal, GU, skin, breast, endocrine, hematologic, and lymphatic. These areas will identify weight changes or fatigue, drainage or soreness, which may be an infectious process, as well as of cough, possible GI illness, and may not be a vaginal discharge at all. It could be a fistula that's going on. They may have potential urinary infection, dermatologic process may be going on. They could have hormonal changes, uncontrolled underlying disorder. There is a possible malignancy or another allergic process. So we can see there's a lot of things that could potentially cause this. So that's why it's important to get a good history review of systems. And next we'll discuss about the physical examination. And it will be largely unchanged from our previous clinical experience, with the exception of the pelvic examination. For this reason, I will spend most of my efforts on normal and abnormal findings of the speculum and bimanual examination, which will be discussed further in the common presentation of abnormal vaginal discharge. It is important to understand during a speculum examination, one should not only focus on observing the cervix, but to also assess the vaginal wall for any potential abnormality resulting in the manifestation of vaginal discharge. The mainstay of H&P findings is that difficult discussion must be completed in order to formulate potential differentials. We have to ask the tough questions. So moving on to our next slide here. Sorry, I lost my track here. Bear with me. My computer went down. Okay, I found it. So the next one is common presentations. So common causes of vaginal discharge in women include bacterial vaginosis, vaginal yeast, and STIs such as trichomoniasis, chlamydia, gonorrhea. Also, irritants and allergic vaginitis, physiologic leukorrhea can be there, and non-specific vaginitis. This literature review was focused on non-STD related vaginal discharge. So this table encompasses the two main causes of vaginal discharge, which is bacterial vaginosis and vaginal yeast. The presentation of vaginal discharge is likely to be broken down by related signs and symptoms, specific drainage characteristics, pH, and odor. Normal vaginal discharge is likely to be clear to / white and has an acidic pH which ranges from 3.8 to 4.2. Bacterial vaginosis is likely to be asymptomatic with homogeneous thin gray white discharge. The pH will be noted to be alkaline in the base and compared to vulval candidiasis. Let's see here. Vulval candidiasis, or the classic fishy odor rather than the fresh odor, is associated with bacterial vaginosis. Vaginal candidiasis may have little to no actual discharge. The majority of what is noted upon exam is likely to be external, but this differential is still considered under the umbrella topics of abnormal vaginal discharge. That being said, has numerous signs and symptoms such as pain, itchiness, and surrounding structure involvement. Other etiologies and common presentions are listed here for you to read. This is not an all-inclusive list, but noting presentation of less common causes of vaginal discharge is to be important to understand when attempting to determine a cause. So next slide is red flags which require action and referral. The red flags revolving vaginal discharge are disease processes associated with a high rate of morbidity and mortality. Thus, they require immediate referral or treatment implementation. This literature review is focused on vaginal discharge, not STI infections. However, one must rule out STIs as they are associated with a potentially life-threatening complications such as HPV, chlamydia, and trichomoniasis, as well as gonorrhea is associated with the highest rates of newly infected individuals. HPV infections are likely to be asymptomatic, and there is a need to reassure women are completing appropriate screenings regimens for their respective ages, and prior screening results are through. On the same note, chlamydial infections can often be asymptomatic in females, but they may present also with purulent discharge from the endocervix. The discharge is likely to be opaque yellow in color, and the infectious process is likely to be associated with postcoital bleeding. Thus, the increase to obtain a thorough H&P to address the presence of this. Gonorrhea must be identified due to the likelihood of it progressing to pelvic inflammatory disease. Gonorrheal infections can be asymptomatic, but the woman may note itchiness, mucopurulent discharge. The STI of trichomoniasis is likely to be identified by purulent, malodorous, thin vaginal discharge. One unique sign and symptom of trichomoniasis is the worsening of symptoms during menstruation, thus the need to obtain menstrual history on all women presenting with vaginal discharge. Once identified, STIs must be adequately treated. Treatment regimens will differ depending on the geographical location and current antibiograms, but there's increasing movement to the implementation of initial dual therapy for chlamydia and gonorrhea infections via rocephin and azithromycin. Vaginal discharge due to trichomoniasis can be noted by a green-yellow yellow frothy discharge and vaginal soreness. However, these signs and symptoms are not solely specific to the disease process, thus the need for further examination. Speculum examination will likely note an inflamed cervix or the strawberry cervix sign. A flagell is the therapy of choice for trichomoniasis infection. This can be prescribed orally or as an intravaginal gel. Fever is uncommon with most forms of STIs. However, if present, immediate action needs to be required due to the likelihood of pelvic inflammatory disease. Oral fever greater than 101 with uterine cervical motion and adrenal tenderness are commonly found in patients with pelvic inflammatory disease. Pelvic inflammatory disease will be treated on severity. The treatment regimen will include cephalosporins and doxycycline as the causative agents are most likely chlamydia and gonorrhea. Bloody vaginal discharge in postmenopausal women indicates a cancerous process that should be promptly result in an appropriate gynecologic referral. And if you note bloody vaginal discharge in postmenopausal women, this may indicate a cancerous process that should be promptly result in a appropriate gynecologic referral. Rectal vaginal fistulas may be noted and can result in abnormal vaginal discharge. Signs and symptoms will depend entirely on the size and location of the fistula, and they may manifest as passing of stool, gas stool, or malodorous from the vagina. If a fistula is suspected, a prompt surgical consult is required. So next slide, here's the diagnostics and there are several of them. So the upcoming discussion on diagnostics will be aimed on non-STDs that may manifest as vaginal discharge. The first is AMSL criteria, which is used to evaluate the presence of bacterial vaginosis. The 4 criteria evaluated are characteristics of vaginal pH and a positive or negative whiff test. I never would have believed that would have been a test, in a microscopic evaluation. In order for bacterial vaginosis to be identified, 3 of the 4 must be present. The AMSL criteria has a specificity, sensitivity, positive predictive value, negative predictive value, and accuracy of 91, 91, 86, 94, and 91% respectively. The whiff test is, and speaking a little bit more about the whiff test, how it's conducted is it's performed by placing potassium hydroxide onto a sample of the vaginal discharge. If a fishy odor is noted, this is considered a positive whiff test. The fishy odor is due to the release of an amine from the exposure from the basic substance. If microscopic evaluation reveals bacteria adhering to the vaginal epithelium, this is considered noting clue cells, which is indicative of bacterial vaginosis. Gram staining for specific bacterial vaginosis will reveal lactobacilli, or the normal flora of the vaginal environment. Another one is another criteria to look at is the Nugent criteria, which is used to quantify bacteria via a gram stain. The Nugent criteria evaluates lactobacilli, bacteroides, and Mobanicus. The results of the Nugent criteria notes a high sensitivity, which is equivalent to the AMSL criteria, but recorded a lower specificity for ruling in bacterial vaginosis. And the AMSL criteria is easy to perform and yields appropriate findings. However, without incorporating gram staining, results may mislead at times, making the Nugent criteria the current gold standard. On the other hand, another criteria is the Hay-Eisen criteria, and it's another gram staining modality which utilizes diagnosis, or which is utilized to make a diagnosis of bacterial vaginosis, and it is a 4-grade scale, and it is the following. Grade 1 is normal, lactobacilli, morphophytes are predominant. Grade 2, intermediate, you'll see mixed flora with some lactobacilli, but Gardnerella and Mobanicus morphocytes are also present. Grade 3, bacterial vaginosis, so predominantly you're going to see Gardnerella and Mobanicus morphocytes with a few or absence lactobacilli. And then grade 4 is aerobic vaginitis with mostly aerobic bacteria. So according to BASH, they recommend utilizing the Hay-Eisen gram staining over the Nugent criteria if intermediate results are noted, as the Hay-Eisen criteria was found to have a greater efficacy at further differentiating between this grouping. If the vulvovaginal candidiasis is suspected, pH testing on a wet mount microscopy should be obtained. Vulvovaginal yeast will be present with a pH of 4 to 4.5, which is more acidic than bacterial vaginosis. The wet mount prep for vulvovaginal yeast will present with budding yeast and hyphae, and this is noted on the upper right image. Culture and sensitivity are useful when the H&P and other diagnostic modalities are inconclusive. If one suspects a sexually transmitted disease or the patient has a recurrent bounce of yeast infections, culture should be obtained to better formulate a management plan. Microscopy can also be useful to the identification of physiologic leukorrhea as the cause of vaginal discharge, as this will note numerous epithelial cells. A thorough H&P should be enough to identify allergic and nonspecific causes of vaginal discharge or vaginitis. X-rays can be helpful in identifying, metallic foreign objects in the younger population, but it won't show up if it's not radiolucent. Diagnostics can be useful in the identification in identifying causative agents or ruling out pathology, but an in-depth history in physicals should be completed prior to the utilization of diagnostics. So next slide is the potential differentials when you have someone coming in with this. As mentioned before, vaginal discharge can be physiologic or pathologic in nature, thus the numerous potentials one can consider if a patient presents with abnormal vaginal discharge. The two most common abnormal vaginal discharges or change to from a prior normal vaginal discharge include bacterial vaginosis and vulvovaginal yeast. Depending on the patient's risk factors, such as age, race, sexual activity, and preference, the list of the differentials will likely change. So the potential alternative diagnosis could include allergic vaginitis, physiologic leukorrhea, foreign body. Do not misdiagnosis, with the foreign body. You don't want to make sure that they have a tampon still there, which could result in toxic shock. Streptococcus, vaginitis, inadequate hygiene, or the practice of excessive douching. Do not misdiagnose. They include cancer of the fallopian tubes, endometrial, or vagina. It's difficult to determine on history alone, but some of the presenting findings are specific to the origin of cancer and sexual abuse. I was unable to find a standardized screening tool or questionnaire to identify sexual abuse, but common findings include disclosure, inappropriate contact, normal physical assessment, and concurrent depression are associated with sexual abuse. The mainstay of differentials associated with vaginal discharge is not to miss the process of associated with severe complications such as cancer and sexual abuse. One should also not miss STIs or foreign objects, as these are also associated with life-threatening complications. If one cannot exclude these diagnoses, attempts should be made to rule out these prior to making a diagnosis. Moving to slide 11, management and treatment. So management and treatment of vaginal discharge will rely heavily on an accurate diagnosis, as there's numerous causes of vaginal discharge. The mainstay of most management and treatment regimen for the various causes of vaginal discharge revolve around pharmaceutical administration. I will discuss prevention and management modalities in the education section of this presentation. As previously noted, there are two most common causes of vaginal discharge that are not related to STIs, and these are bacterial vaginosis and vaginal yeast. So the first line, pharmacologic therapy for bacterial vaginosis is Flagyl, which is an antimicrobial. It is a bacterial agent that is thought to disrupt anaerobic bacterial DNA synthesis. It is contraindicated in first trimester of pregnancy, prior to hypersensitivity actions, concurrent alcohol use. It should be cautioned in patients with hepatic, blood, and CNS impairments. Side effects include seizures, meningitis, and neuropathy, as well as Stevens-Johnson syndrome, leukopenia, nausea, vomiting, diarrhea, dizziness, yeast infections. Flagyl can be given orally or intravaginally as a gel. Orally, it can be given at 500 milligrams twice a day for 7 days. It is the standard dosing for non-reoccurrent bacterial vaginosis. It can be given as well as a gel, which can be prescribed for 5 days as one application, 5 grams daily. The intravaginal form of Flagyl has been associated with fewer side effects compared to the oral form. So if individuals experience GI symptoms and they're stopped taking their oral Flagyl, you can switch them to intravaginal form. If the use of Flagyl is contraindicated, intravaginal clindamycin can be looked to as another treatment option. Oral clindamycin is a second-line agent for non-pregnant females. In pregnant females with confirmed bacterial vaginosis, the first line would be Flagyl, or it could also be clindamycin 300 twice a day for 7 days. Recurrent bacterial vaginosis, where there's more than one bout of it within a year after successful treatment in the non-pregnant female, Metrogel should be prescribed for 4 to 6 months, and that is given intravaginally as an application twice a week. In pregnant females, high-dose Flagyl can be prescribed. It should be noted that with trichomoniasis infections are also treated with Flagyl in the forms of 2 grams orally as 1 dose. So this may lead individuals thinking, well, should we just give 2 grams to all patients with bacterial vaginosis in case if they have a trichomoniasis infection, as it could also be present. However, research doesn't support this, and a single dose of Flagyl is ineffective against bacterial vaginosis. So vaginal yeast infections are treated with an antifungal agent. In regards to treating vulval vaginal yeast, it is important for that one identifies if the yeast infection is complicated or uncomplicated, as this will affect the course of therapy. Uncomplicated infections are mild to moderate in presentation with fewer than 4 episodes per year. On the other hand, complicated vaginal yeast infections are noted to be moderate to severe in presentation. Individuals will have more than 4 infections within a single year. Microscopy notes that only budding yeast and host factors. So, and then moving on, for agents to treat uncomplicated yeast infections include budoconazole 5 grams intravaginally times 3 days. Also, you can look at nystatin, 100,000 units vaginally tablets for 14 days. Lastly, fluconazole, 1,500 milligrams orally. The intravaginal forms are known to weaken condoms and diaphragms, so education should be provided that secondary forms of contraception should be used during therapy. Of the previous listed agents, there's a little difference in the efficacy, so depending on what you're going to prescribe the patients is going to be what's available, patient's preference, and the cost. As for complications, infections, there are only 2 for complicated infections. You're only going to have 2 to pick from, and that's going to be fluconazole and clotrimazole. Sorry, I could not pronounce that. So clotrimazole is given as 100 milligram vaginal tablets daily for 7 days, whereas fluconazole is given as 150 milligrams every 3 days for 3 doses. For patients with recurrent vulval vaginal yeast infections noted by more than 4 infections in 1 year, or if a woman with uncontrolled diabetes or who are debilitated or are immunosuppressed, clotrimazole can be given as 500 milligram vaginal suppositories weekly for 6 months, or fluconazole can be given as 150 milligrams weekly for 6 months. So lastly, I'll go ahead and touch on some more rare ones, atrophic vaginitis and allergic irritant vaginitis. Estrogen therapy is the mainstay treatment for atrophic vaginitis. Estradiol therapy or estrogen intravaginally can be utilized in the management of the disease process. However, unopposed estrogen should not be utilized in women of reproductive age or still have an intact uterus due to the risk of cancer. Also, estrogen therapy should be prescribed to the lowest dose for the short amount of time as possible. Allergic or irritant vaginitis management will require a thorough history to identify offending agents and require strong patient education. Most common offending irritants include latex, practicing douching, bubble baths, the use of feminine sprays. Upon the removal of these irritants, the woman's vaginal environment is likely to return to its pre-vaginitis state. Simple, sympathic mimetic therapy via emollients or gels can help reduce irritation or itchiness. So as you can gather, the management and treatment of vaginal discharge can be difficult due to the number of potential processes behind the manifestation. That being said, with thorough H&P and with the assistance of diagnostics, a likely diagnosis can be made. The mainstay treatment for bacterial vaginosis and vulvovaginal yeast infections revolve around determining the severity of the disease and prescribing appropriate management therapy. So next slide is patient education. So many of these vaginal discharges are preventable, so a heavy weight needs to be placed on prevention. Primary strategies can be looking at the entire population, so all women front to back cleaning, avoiding douching, or aimed at a specific population. So a woman who partakes in douching may have a mindset that she's actually cleaning her vagina, reducing her infection. However, evidence does not support this. Rather, it is recommended that this practice is associated with increased rates for infection. At the beginning of this presentation, I discussed risk factors increasing a woman's lifetime likelihood of developing abnormal vaginal discharge. If we have the ability to identify these populations, we can develop strategies to decrease their risk. For instance, women who have multiple sexual partners and who partake in risky sexual practice are at an increased risk for developing discharge secondary to an infective process. Condom usage has shown to decrease STI rates. However, it's not directly associated with a reduction of bacterial vaginosis rates. That being said, prior STIs are risk factors for developing bacterial vaginosis and yeast infections. Thus, one can promote gather condom utilization will in turn decrease abnormal vaginal discharge rates. You could look at the administration of probiotics such as a lactobacillus supplement, which may decrease the rate ineffective vaginitis. Evidence behind these practices is an attempt to maintain normal flora in the environment, as we've learned that changes to the normal flora can lead to pathologic discharge. Patients need to be educated on side effects of the meds that we are prescribing. For instance, women who are prescribed flagyl should not drink during this or after the administration for an extended period of time. For non-infective cases of vaginal discharge, specifically atrophic or allergic vaginitis, the continuation of sexual activity and practicing avoidance of irritants may be enough for the management of these disorders, and you don't have to prescribe them anything. So our second to last slide is going to be up next, and that's monitoring and following. And the majority of vaginal discharges caused by bacterial vaginosis or yeast infection are cured with no problem. However, recurrent infections can lead to complications. Complications of recurrent infections can lead to excoriation or scarring, thus increasing the rate of sexual dysfunction. Recurrent infections and prolonged vaginal discharge are likely to weigh on a woman's psyche, increase her overall stress level. However, our follow-up for bacterial vaginosis and yeast infections are usually not necessary. That being said, if reoccurrence happens, patients should return to their primary care provider to initiate a management plan. Recurrent bacterial vaginosis may be managed with a second-line therapy regimen due to inadequate results from the first attempt. However, one should assess the regimen adherence and evaluate the patient's education to ensure that the patient is going through what you prescribed for them. If they are not, we should re-educate and go back to initial therapy if possible. So now we're going to go to the last slide, and that's just wrapping everything up. So abnormal discharge may be infectious or it may not be. Non-infectious processes include normal process like physiologic leukorrhea, due to hormonal changes or discharge secondary to a foreign body. Infectious processes including bacterial vaginosis and vulval yeast infections, as well as STIs or vaginal Streptococcus vaginitis. Some causes of vaginal discharge can be determined on a clinical basis only, such as allergic vaginitis. On the other hand, vaginal discharge secondary to an infectious process will likely require diagnostic testing, which is noted by a clinician suspecting bacterial vaginosis, but cannot rule out trichomoniasis that is associated with severe complications. The majority of vaginal discharge secondary to an infectious process is not due to an STI. Rather, they are caused by bacterial vaginosis and yeast infections. Treatment of these two processes revolve around pharmaceutical management. That being said, education must be provided on preventative strategies so we can reduce these from occurring. Vaginal discharge can be extremely trying time for a woman, and it must be managed appropriately. Obtaining a thorough H&P will be priceless in the identification of potential differentials. Diagnostics can be extremely beneficial if the process associated with severe complications cannot be ruled out. The majority of vaginal discharge cases can be treated with a good cure rate. In order to assure a cure is obtained, education must be aimed at prevention, and the education of at-risk educations or individuals must be accomplished. Vaginal discharge is a common complaint and accounts for numerous gynecologic visits each year. As the next generation of clinicians, must be able to adapt and identify, manage, and empower our female population. Thank you guys for listening to the presentation. I hope you have a great day.